I'm Leslie McIntosh, and I'm going to be the moderator for this. I am a professor at Washington University, and I also have founded and oversee the St. Louis Machine Learning and Data Science Meetup, which is free to attend if anyone's interested. But we're going to have each of the panelists here introduce themselves. And before I forget, this is also sponsored by 1904 Labs. And we had a slide, but everybody should have in their possession one of these big and fast data maturity models that we're going to go over during this session. So.
Hi, I'm Laura Tellman, and I'm with BJC Healthcare and Washington University School of Medicine. My background is in anything really related to data. So right now I'm doing enterprise data governance for both BJC and the medical school. And in the past, I've done data integration, data broker services, and apps that are collecting data. Thank you.
With BJC.
Right. So at BJC, I'm going to say that we're at 3 bridging into 4, and I'm going to talk a little bit about why I think that is. So we're more of a holding company as opposed to an enterprise system. And so we were best of breed until about 5 years ago. So we had many applications all trying to be integrated together. I can't remember the number. At some point, it was like 440 different just clinical apps trying to be integrated. So what we're doing is standardizing our operational systems, and some of those are in the cloud and some of them are on-premise. And so that's been very helpful from a data perspective. And then in addition to that, we're doing master data management in a couple of different areas. Patient is one that we've been doing for a while, but we're also moving into the provider space. And our location, which has been really interesting. Me being a little bit of an optimist, I thought, location, how hard can that be? So that's where we are there. In terms of our warehousing, we still have a lot of warehouses, but they are trying to sort of crystallize around certain functions, and we are going to dabble next year with 2 of those going into the cloud. So I think there's really sort of 2 big things that are moving us along in terms of driving our maturity. One is mergers and acquisitions, because hospital systems are going through a lot of that right now. For the most part, our processes around that are to get them onto our standard operating systems first, because most of those we've already built good interfaces to our warehousing and other analytics environments. So that's sort of our strategy around the mergers and acquisitions. The other one that's a bit more challenging right now is the move from fee-for-service to, pay for performance, and being much more aware about who your population is, what all their issues are, what are their social statuses, how are you going to get outside of the critical acute care space and into every aspect of their lives so that you can keep them healthy. So there is where we're trying the cloud-based analytics products being offered, and hoping that we can link our data in much the way that retailers and other people have been doing for years, so that we can understand the bigger picture of the patients. I think for the most part, we're trying to build models where the operational systems like the ERP, the electronic health record, the finance systems are going to handle what they need to handle when they don't need to integrate data, right? So they should supply the operational needs that don't need all the connections to everything else. But I get involved in the bigger challenges where we're trying to integrate that data in order to do things. And just to give you some examples, the sorts of things that we're doing in real time are, for example, screening every drug that is prescribed within the hospital within 10 seconds to make sure that we're actually prescribing the right drug to you. And that means that we're looking both at your clinical data to make sure that your body can accept that drug. We're looking at the history of drugs that you've received to make sure there's going to be no interactions on that drug, those sorts of things. So and with that, we are having to pull this data together, which today is still across I think it's 240 different clinical systems, right, in real time in order to put the decision support on top of it and build those sorts of clinical alerts. So that's just an idea of what's going on sort of the operational sides from the clinical perspective. Another big one in terms of our operations is the number of denials that we deal with. So claims processing, although very electronic and has been around for a very long time, the rules and all the things that you have to be in place to make sure that that claim actually processes is getting much more complex. And we have a huge effort right now around trying to make sure that when we submit a claim, we only have to submit it once. That's being optimistic, of course. Okay, then on the research side, we don't have to worry as much about the latency of the data in some of our situations, right? So obviously, if you're on the research side and you're trying to find the right people to be in a clinical trial, you still need that sort of real-time data. But a lot of it is looking at past and post sorts of things, right? So whether or not I should do a study should be based on what my population looks like and the number of patients I think I'll be able to recruit into a trial. That's your historical data, so making sure that that stays up to date and can be utilized and accessed by people. That's a big area of effort for us because a lot of our research data we partner with the medical school on, and so getting these two non-legal organizations to share data and to do it in such a way that benefits both sides is an interesting opportunity. So I do think it is a challenge. I'll talk about a couple of the things that we're doing. So first of all, we think a lot about partnerships and consulting help because a lot of what we're doing is very new, and we don't want to try to go through it on our own at the speed with which we could try to do it on our own. And so partnerships and consulting help has become pretty core to our work. One of the things we try to do there is if it's something that we want to improve our skill on, we make sure we write into the contract how that's going to happen. So that transfer of knowledge between that partnership or that consulting firm and to our own individuals is part of the contract. So that's one area. In terms of building our own, recruiting process and onboarding process, at least for me, I'm of the mind that my people may not stay long. The people who will stay with me are the ones that just really are passionate about changing healthcare. But if you're driven by money or other motivators, you're not going to stay with me. But it doesn't mean that I don't want you as an employee. So we've really looked at clarifying what the roles and responsibilities are, being very clear about what an onboarding process and what a training can look for or should look like, and then finding out who can help us train people. So looking at different avenues for where you can get the training that you need as opposed to trying to build it all in-house. And then, like many people, you build very clear 90-day plans so that people understand what's expected of them and sort of you can see if they're ramping fast, right? Because if not, then you need to do something different with that. Then I guess those are really the two main points. I was going to talk a little bit about sort of the other softer skills, but I think I covered it, so. So I think a combination of those things. I think probably the thing that we do the most is we've got an onboarding process that, literally, in our data broker space, I think we have 3 new hires about every 6 months. And so we've had to build a really good onboarding process for these people. And so we make sure that we are hitting the things that we want them to learn, and we do it partnered with something they have to deliver, right? So that they are productive usually within the first 6 weeks. We start them out with writing queries, right? And you just say, look, within this first 6 weeks, you're going to be doing these queries, and then we just move them on to other things as we want to position them. But the other things we're looking for, which gets to your point, is we want to partner with educational systems and people who are building these data science training programs and bring a little bit of it in-house, right? So bring a little bit of those training programs into our space, but also find ones where we can send people for additional training depending on what we're looking for. Definitely have experienced issues with data quality, and I would say that I think the biggest thing we're doing is the data governance around that. And you know, he spoke about it a little bit earlier. We are aligning stewards within the organization that, you know, it's not their full-time job, but we're making it very clear that there are people who are responsible for the quality of the data. And we've got stewards, and then we've got what we like to call trustees, which are like VP level people in the organization that are now going to be held accountable for the data that they are trustees of. And I think that's probably the biggest thing that we're doing that I believe will improve the quality of our data, is by just making it clear who's the throat to choke and who's the person to talk to when you have a problem. Because currently it just gets passed around, right? The business side thinks it's an IT problem, the IT side thinks it's a business problem, and the thing just circles around and circles around and circles around. So the way that we've been able to, I think, make a really good change is by creating this responsibility matrix.